Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Jennifer Clarke, Rhode Island Department of Corrections. How did your passion for the treatment of opioid use disorders in correction facilities start?
Well, I started as a primary care physician in 1998 at the Rhode Island Department of Corrections. And even then, I was a little amazed that we didn't provide methadone to people when they came in. I was used to it in the hospital, that we would continue people on their treatment. So this is something that I've wanted to do for over 20 years.
How did the MOUD program in Rhode Island start? What are some of its challenges and successes?
We started right around the same time that I started my job as medical director. So I had been a line staff physician for many years, and then I took the position of medical director. And we were very fortunate that the governor, Gina Raimondo, instituted the task force for opiate use disorders and trying to address all of the deaths that were occurring because of overdoses. And I was asked to propose a budget. And fortunately, I'd had 18 years of dreaming up my fantasy program. So I was able to come up with it fairly quickly. In fact, within about 2 or 3 hours, we came together with a plan. And the plan was to use all 3 FDA-approved medications and to treat 3 different populations. First population, people coming in on treatment. We decided we would keep everybody on treatment for up to a year. Second population, people coming in and withdrawing from opiates. We wanted to make available the treatment that would work best for that individual patient, so do an individualized treatment plan and start that person on treatment. And then the final population, which people had the hardest time with, was starting people on treatment prior to release. Now, people would tell me they haven't had any opiates for 5 years, for 10 years. Why would you restart an opiate? And I get it. It doesn't make sense. But if you think about addiction, it's a chronic relapsing disease. And we had done studies on smoking cessation, and people would start smoking even after 20 years without a cigarette within an hour of leaving the prison. So people don't want to be on a methadone program. Nobody plans to, go to a clinic every day. That's not generally what people want. But if people are really engaged in recovery, then that is something that they want. And our patients generally know if they need treatment, they want to start it before they're released. And I think it's the most shocking thing for people who are not involved in corrections, that people get scared before their release. They know that they're going back to a similar environment. So we want to do the most that we can to help somebody succeed in the community.
Why does the risk of overdose death increase for individuals not on medication upon release?
When somebody comes into a correctional facility, and if they're taken off of all opiates, either illicit or prescribed, their tolerance will start to go down. The receptors in the brain build up again. And when somebody uses the same amount as they'd used in the past, it will then cause them to overdose and as we've seen, there are many deaths that occur right after release if people go back to using the same amount. I think it's also important not to just focus on death. I mean, that's something, of course, as a physician, we want to avoid. We don't want people to ever die, but that's not the only thing that's important. What's important is people get their lives back. So their lives with addiction just focuses on the drug. When people start treatment and are in recovery, they can be a parent again. They can be a sibling. They can be a son or a daughter. It lets them engage in the community. They start working again. So it's more than life and death. It helps somebody live to their fullest potential.
How was staff buy-in during the planning and implementation of this process?
I was surprised by some of the medical staff being more resistant to the treatment program. I wasn't surprised by security staff being resistant, but I really felt that the medical staff would be familiar with the literature and wouldn't be as resistant. Eventually, people saw that there were fewer issues. People weren't as sick when they came in. We were able to get people more engaged in other areas of recovery. So going to groups, dealing with other mental health issues, that was something that eventually got people on board. There are always going to be people who are going to be resistant to a change. That's just the nature, I think, of any institution or any organization.
What advice would you give to another facility implementing MOUD?
My advice, some of the mistakes that I made, I didn't get a group together early enough. I thought that because it was a medication, that I could do it with just the medical staff. I didn't get security involved as quickly and as completely as I should have. I was very lucky that I had support from above, support from the director, support from the wardens. So I would suggest just going out a lot to line staff, understand what their concerns are, make sure everybody is educated about the reason for medication and how each individual each patient is treated as an individual. So we don't have one treatment plan for everyone. We're dealing with individuals, and just like other medical conditions, we will treat the individual, not just treating the disease process.
How does it feel seeing the success and continuation of this program?
On a personal level, it feels great, but the challenges in corrections are huge. It's not just opiate addiction. I think it's really brought out for me the need to do more for alcohol use disorder, for other disorders. Probably not what you're looking for, but it's great that we're able to move ahead with this issue, but there are so many other issues that we also have to address. The good thing about this is it's really opened up communication with corrections and the security side of the house and the medical side of the house. So we're trying to work together more and more to provide more complete treatment for the patients that are in need.
What is your next dream for corrections?
Currently, sometimes people think this is my only job, but this is a small piece of what we do. We are trying to eliminate hepatitis C. We're trying to get everybody treated, everyone vaccinated. There are outbreaks of hepatitis A now, so we want to make sure that when people leave the system that they go out as healthy as possible. mental health conditions. We want to make sure that people are stable and have a seamless transition with all of their problems so that they can do the best that they can in the community. Make sure they have access to the medication. They feel comfortable with community providers. The goal, I believe, for the whole institution, it's public safety, which, if in its broadest definition, would include public health. So to have people leave as healthy as possible, that really contributes to public safety.
Do you have any other advice for facilities starting an MOUD program?
I believe it's really important to let people that you're working with express their feelings. Don't run away from the questions or the concerns that the security staff have. Try and be as flexible as possible. And when we work together as a team, then we're doing what is best for the patient.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.